reality, it's a very few patients in there with a colostomy, and some of them actually is a temporary colostomy. If we find that there is tumor down in the pelvis and involving the rectum and the anastomosis, which means the reconnection is too low in the pelvis, then we do a temporary ileostomy to let the anastomosis heal, and then the ileostomy is put back. We will leave a colostomy usually. It's like in extreme cases when we had done maximum debulking and that was the only option left for us. But we try to reconnect these patients because we know it's better to reconnect them because they have better quality of life and the nutrition is more manageable with these patients. Now, what should I expect? Obviously, for each of the three of us, the protocols of recovery are slightly different because of the organs that we do or because of how we manage. We have a universal protocol that we use for our patients. We have a rapid recovery protocol for all our patients that come for a Hipec. They get actually a pre-screen from a team of anesthesiologists to optimize them. We optimize their nutrition. I refer these patients as well to the rehabilitation, pre-cancer rehabilitation, so they can start getting strong before the surgery. So we have a team, we have the surgical nutrition team, the rehabilitation team, the anesthesiology team that will see these patients before we go to surgery. And our intent is that under this protocol that is called ERAS, these patients get discharged from the hospital quickly. The average for our population of our patient is actually between 8 to 10 days in the hospital. Of course, there are patients that could go way longer than that and patients that can be discharged even sooner than that. But the average is around 8 to 10 days. But it will depend on what organs were removed, if they were drains, that they were different in anastomosis. So it's dependent. But that is, if everything goes as expected, usually the patient will be in ICU for the first 48 hours, mostly because we have to monitor the kidney function so they can wash out the chemo. And we actually, our protocol, we extubate the patients after the surgery. And they go there just for that monitoring, and then they go to the floor, and we expect these patients to be walking around the day after the surgery, to be moving around, and we very expedite removing the nasogastric tube and getting them feeding. And we have been very successful with that protocol and getting patients discharged safely to home.